live in 5, 4, 3, 2, 1. We are live now.
Good evening and warm welcome to the 10th session of Healthy Life Initiative of OrthoTV. In this webinar series, we discuss various topics related to health. We provide scientific information without any commercial influence. That's the most important thing which we would like to highlight, that there is no commercial interest in these webinars. I am Dr. Dhiren Ganjwala, a pediatric orthopedic surgeon practicing in Ahmedabad. The topic for today's webinar is diet tips for a person with diabetic or who is pre-diabetic for better control of blood sugar. We have three experts with us who are not only great clinicians, but they are also academicians also. The first is Professor Sunil Mishra. He is going to join soon. He is an endocrinologist and diabetologist practicing in New Delhi at Medanta Hospital. He did his DM endocrinology from AIIMS, New Delhi, a very famous institute, and he's practicing at the Prime Institute of India. Dr. Mahadev Desai, a senior physician practicing in Ahmedabad for last 40 years or even more than that, always updated in the knowledge, and he's most important, very well recognized for his balanced view. Over and above that, he is great contributor in a series or a platform which is Netflix. Netflix is similar to OrthoTV, but it's committed to mainly internal medicine and the medical topics. And it brings out update on the medical topics very regularly. And Dr. Mahadev Desai is very active on that. The third participant is Dr. Pramod Tripathi. He is practicing in Pune. He has become synonymous with the word diabetes reversal because he's the one who popularized this concept of diabetes reversal to the non-medical people. There are many other doctors who are doing this for the medical community, but Dr. Pramod Tripathi is like spreading the knowledge about the freedom for diabetes or diabetes reversal. And he has a very popular YouTube channel. So I would recommend that if you are interested in controlling your diabetes or diabetes reversal, please watch his interesting talks on the YouTube. The disclaimer I would like to mention first before we start, that this webinar is mainly for the information. The information which we are going to apply or we are going to suggest before you apply into your management, please consult your physician. That's very important because our opinion is not the final one. Your physician is going to be the important person for your diabetes management. OrthoTV, our experts or I are not responsible for any problems arising because of that. Now coming to the most important point, why this topic? Why we have selected this topic? And to give you the idea about that, let me give you the few simple statistics. How common is diabetes in our India? The recent statistic says that the prevalence of diabetes in India is 11.4%. Over and above that, 15.3% are pre-diabetic. So if we combine these two, it comes to almost 25% or more than that of the Indian population is diabetic. And that's why this webinar is trying to affect or give information to 1 out of 4 Indians. According to current definition of the diabetes of the World Health Organization, the major criteria is the glycosylated hemoglobin, or which we call it HbA1c. If it's less than 5.7, the person is called non-diabetic. If it is between 5.7 to 6.5, it's called that the person is having a pre-diabetic stage. And anything more than 6.5, that is definitely a diabetes. We all know that there are two types of diabetes. The one which we are going to discuss today is type 2 diabetes, which is basically of the insulin resistance variety, and we see most commonly in the adult population. So most of our discussion is related to type 2 diabetes, and which we call it that it's because of the insulin resistance. Diet, overweight, stress, lack of exercise, inadequate sleep are the major reasons for diabetes. And a lot of people call it that the type 2 diabetic people are carbohydrate intolerant, means they are not able to tolerate high amount of carbohydrate in the food. And for that, controlling the intake of carbohydrate is one of the important goal of the treatment. And so we are going to discuss about that. The another reason why we are discussing this topic is there are a lot of misconception prevail amongst the non-medical people about the diet related to diabetics. And we try to clear out these misconceptions in our discussion. And many of our medicos and the non-medicos people are watching this webinar. We will discuss this subject in a very basic level. We are not going to discuss something hi-fi, and we will be discussing without medical jargon. And due to time constraint, we will focus only on the practical tips. If you have any question, you can ask your question to me on my WhatsApp number. That's 97129 25600. I repeat, 97129 25600. So please feel free to ask questions. Now we start with the question. And the first and the simple question I would like to ask Professor Sunil Mishra about why we really need to control diabetes. Because like time and again, we say that this is very important. If you don't control diabetes, there will be a problem in later on in the life. So can you explain why we should control diabetes? Over to you, sir.
Thank you. So thank you very much, Dhiren. It is very important to know about the diabetes, right? Because it's a chronic illness, and diabetes is because of the insulin deficiency that we need to understand, and we need to reiterate to our patient every time. Type 2 diabetes or type 1 diabetes, these are the artificial classification. There is a spectrum of the disease. Type 1 diabetes means around 80% of the insulin capacity is already lost. So they cannot control diabetes, they cannot survive without insulin. So they must have to take insulin. Because they are in such a dire need, they cannot control diabetes without insulin, so they understand the value of the insulin. The other type of the diabetes, what we call a so-called type 2 diabetes, it is also insulin deficiency state. It doesn't mean that type 2 diabetes means no insulin, right? And many times our patient want to hear that thing is, okay, it's type 2 diabetes, they are very happy, like it can be controlled with the diet and exercise or with some medication, and I may not have to take the insulin if advised to me. So that's wrong. The crux of the diabetes is that it's a slow insidious disease, majorly asymptomatic. That means there are not going to be major symptom otherwise, and complication happen because of the unregulated high sugar for long term, because there are many cells which do not require insulin for the entry of the glucose into their intracellular space. So therefore, when that high glucose for very long term enters those cells, that start damaging the intracellular structure, which are mainly made of protein. Right? Because of this high glucose, the cellular structure start getting damaged, and in long run, that start reflecting into the complication, or I will say in a simple term, damages in the various organs. Because many times people do not understand what does mean by complication. So we have to tell them, no, it's not, it's damage in the various organs. And those things start reflecting after 8-10 years. And once start, then there is no looking back in those complications. Now, no disease is so simple, right? It's very easy for a doctor, fraternity, that you have having very simple. Nothing is simple. I don't know who wants to have a disease. Diabetes is also not a simple, but a diabetes without complication is still very simple. And diabetes with complication means a disease with cost of treatment, quality of life, and the longevity. All things are affected. of you must be knowing that what kind of the complication in the body. No organ is left, right? Every organ can get complication. Therefore, as you rightly pointed out, that it is very important to have sugar control from the beginning, and it is important to know that diabetes is an insulin deficiency state. Of course, we will keep discussing in our discussion that what else we can do for that. But from the beginning, you have to hear that loud and clear that if your doctor suggests you insulin, do not run away from insulin. Control diabetes. Over to you.
Okay. Yeah, good. So you clarify that the initial 8 to 10 years, there is only a hyperglycemia, increased blood sugar. The patient is mainly asymptomatic. Later on, it affects both quality as well as quantity of life. And almost every system of the body, organ of the body is affected with diabetes. So with that basic understanding, we go to the next important point, and that point I would like Dr. Mahadev Desai to elaborate. Sir, what is the importance of regular checkup of blood sugar at regular interval, and why we recommend patient to carry out that investigations regularly? So can you give us brief idea about that?
Sure. First of all, thank you very much, Dr. Dhiren, for giving me such a good platform in the company of Dr. Mishra and Dr. Tripathi. It's really a pleasure to be here. And as Dr. Mishra has rightly said, that because the diabetes remains asymptomatic for a large time, it's better that we go for the regular checkup, and we insist and educate the patient right from in the earlier visits only that regular checkup is very important, because many of the complications may be picked up only on the investigations. Suppose retinopathy, by the time the vision is completely lost, we have enough indications beforehand that if we can intervene properly, we can save the vision. Likewise, nephropathy, if we have a regular checkup of microalbuminuria, then probably we can pick up the diabetic nephropathy much earlier. Likewise, when we examine the patients, we go for the peripheral pulsations, blood pressure, ECG, electrocardiogram. They are all very useful tool to pick up, and many of the complications can occur even without the symptoms which we find. Say, myocardial infarction can be there without symptoms of pain. Likewise, as I said, nephropathy, they all can occur without patient having any of the complaints or indications earlier. So regular checkup in the form of complete blood counts, urine examinations, all kinds of blood sugars, fasting, ppps, HbA1c, urine microalbuminuria, lipid profile, ECG, and fundus examination should be a routine at least once in a year. If the reports are abnormal, we may do it more frequently, but this is what we need to go for it. Now, coming to the blood glucose, the simplest way is the bedside glucose meter, which glucometer is a trade name. So ideally we should be calling glucose meter, but everybody calls glucometer, so it's fine. So glucometers are handy, inexpensive, and will give an instant reading, and it's an real-time reading. As against that, we also have now got another instrument which is called a method called continuous glucose monitoring. So blood glucose monitoring has its own advantage. Continuous glucose monitoring has its own advantage. The blood glucose can pick up the most important one of the complication is hypoglycemia, which could be life threatening. So that is something when we tell the patients right in the initial visits only, more so when the patient is on drugs like insulin or hypoglycemic drugs, then we have to explain them about the symptoms, warning signs of hypoglycemia. And any of these signs, if the glucometer is available, then we need to document. If it is not available, we don't wait. We simply treat in the with the diagnosis that it is hypoglycemia. If it occurs too frequently, again, that could be an indication that whether patient's dose is high, or he might be going for complications like nephropathy or maybe the liver involvement. So that's why we need to go for the frequent blood glucose checkings. Many times, as we say, the patient doesn't have symptoms. So unless he checks his sugar, which could be 200 or 250, he would not know that his sugar requires to be controlled. And now we have enough data to say that if we control blood glucose, definitely we can prevent the long-term complications of diabetes. Coming to continuous glucose monitor, it's a new kid in the block, but very important for its select patients. Whenever we find a patients with erratic reports, fasting is low, ppb is very high, or HbA1c doesn't correlate with the fasting or ppbs, then it's better that we have some device which can give more readings in a shorter time. So continuous glucose monitoring is one device in which we have got a sensor, we have got a transmitter and a recorder and monitor. So this is all a very small patch which is applied over the arm, and it keeps sensing, recording, and sending the reports to the monitor or a reader. It could be real time or it can be picked up later on, but that gives reading every 5 minutes. The main difference is that continuous glucose monitor measures interstitial blood glucose, not the capillary blood glucose which we measure with the glucometer. So, but practically the lag of only 5 minutes, right, which may not be important in most of the routine cases. Continuous glucose monitoring gives the idea about we can convince the patient that if he takes certain foods, his glucose goes up, right? Or maybe his HbA1c remains in the normal range, but his fasting ppbs are not in the range. So that is possible when we do continuous glucose monitoring, which gives almost about more than 50 readings in a day. And that gives the idea of the lows and highs. And at odd hours when we can't measure, right? And we can correlate with the food also. Only thing that we have to remember now that the continuous glucose monitoring will be used more often. That certain terms like time in range, time above range, and time below range. What is time in range is that most of the reading, that is 70% of the reading, should be between 70 and 180 milligrams. That is called TIR, or time in range. Time above range is that at least 20, not more than 25% of the reading should be above 180, above 180 milligram, and that too at least not more than 250 milligram percentage. Likewise, time below range, which is hypoglycemia, which is less than 70 milligram, not more than 4% should be below range. And out of which the severe hypoglycemia, which we label as when the blood glucose is less than 54 milligram, should be less than 1%. So over 24 hours, if we say how much time patient has spent in the regular time in range, how much above the range, above below the range, and accordingly, and looking at the chart at what time the sugars are high or low, we can adjust the diabetes medicine dose. So it's very, very useful. Only thing is it may not be applicable in very ICU setup, and of course its cost is there is an issue, but by and large it's a very good addition to our armamentarium for diabetes control.
Okay, sir. Thank you very much for giving us idea about the various investigations. So what you emphasize is that most of the complications are asymptomatic, and unless and until we proactively go for investigations, we will not be able to pick them early. So yes, that's very important. Now coming to the most important point, and what is our discussion is, and for that I think the right person is Dr. Pramod Tripathi. Dr. Tripathi, you have popularized the terminology diabetes reversal. So I would like to ask you the very simple question that what percentage of your patients you are able to maintain their glycolated hemoglobin less than 5.8, means in a normal range without medications, only with the help of diet. So can you tell us about your experience about that? You need to unmute. Yeah.
Sure. It's always a delight to talk about diabetes reversal. And recently at the RSSDI conference in Mumbai, we presented data of normal BMI Indians between 18.5 to 25 BMI, in which we find almost between 35 to 40% Indians lie. And we looked at the remission data of 1,136 patients within normal BMI, and our percent was 25.2%. 25.2% within the normal BMI, we could get them into remission, which was below 6.5 HbA1c for minimum 3 months, not 5.8, which you were asking. Yeah. Okay, 6.5. Below 5.8, we might have to do some more number crunching and actually come to what the data is. But given the international standards of keeping the HbA1c below 6.5, this is the data for normal BMI. When you see a lot of Indians and we handle big crowds, we find that the interesting patch is between 25 to 28 BMI. Just little overweight. And within them also, those who have less than 6 years of diabetes versus those who have more than 6 years of diabetes. the remission percentage changes. It changes, definitely changes. It might go up to 40%, 35 to 40%, and also age of onset. If the age of onset is early, which means less than 40 years, we see the remission percentage drop. It can come to anything between 15 to 20%. So there are many characteristics on which we've done a lot of dicing and slicing of our data and presented at various conferences, also full text articles which you can go through and understand. But the good news is, if we work on the diet and exercise and stress management and overall habits over a long term, there are changes which are substantial, significant, that people can experience and have a much more vibrant life.
Yeah, so that's very important. And what you said is very right, that there are three important pillars. The first is diet, the second is exercise, and the third is stress management. If you combine all of this, then probably 25 to 30% of the patient can come under the glycolated hemoglobin less than 6.5. That's really good. And you really gave bifurcation also. So I would like to ask Dr. Sunil Mishra, what is the reason for why some patients, they respond to the diet control and some patients, they don't respond to that? Can you share your experience about that? Dr. Tripathi already gave a few factors, but what about your experience?
See, if you look back where we started thinking about the pathophysiology of the diabetes. So if you go to the medical journal around 2000, you will see that there are reams of the paper where the type 2 diabetes pathophysiology revisited kind of the articles started coming up. That was because when we start having accumulation of the data from the bariatric surgery experience, where the people start losing after significant amount of the weight, bariatric surgery, and many people stopped requiring medication and were able to stop insulin. So that was the first kind of the data that came into the limelight, that the type 2 diabetes can go into the remission. Okay, what happens in the bariatric surgery? Because there is immediate change in the diet, and around 20 to 40% weight reduction might happen, and that weight reduction helps in the diabetes remission. We have had a paper from our hospital itself. It was Diabetes Technology and Therapeutics we published, and the remission rate of it was still in the people who underwent the bariatric surgery, around 58% of the people were able to go into the diabetes remission. So that is there. Now, when we come about the diet and the dietary modification and the diabetes remission, the first and the most authentic paper and the peer-reviewed articles were by Dr. Roy Taylor and the group from Newcastle. So the direct trial and its subsequent publication by the Roy Taylor and group suggested that when people were provided with the low-calorie balanced diet, 800-calorie balanced diet, between 2 to 8 weeks, more than 60% of the people were able to go into the remission. Now, when they bifurcated the data, who are the people who were going into the remission? So 2-3 key factors depends, which probably the answer you want from me. Number one, the amount of the weight reduction. The more is the weight reduction, more is the probability of the type 2 diabetes going into remission. So above 10-12% of the weight reduction, there is a significant higher proportion of the likelihood of going to remission. More than 15%, more than 50-60% of the people will go into the remission. So number one is the key amount of the weight reduction. So if you tell your patient lose around 12 to 15% of the weight reduction, there is a fair possibility that you will go into remission. Second thing, which Pramod also, Tripathi also spoke about, the duration of the diabetes. So people who are early in the course of the diabetes, because as we know, the type 2 diabetes is a progressive disease. Look at the UK PDS data, the newly diagnosed type 2 diabetes. At the onset, the amount of the insulin lost around 30 to 50%. So in the beginning, newly diagnosed diabetes, they have already lost a significant amount of the beta cell reserve, and it will keep happening during the lifetime. Therefore, at some point of the time, people will also require insulin. It is because a progressive degenerative disease. Okay, so beta cells are declining in term. Therefore, people need more and more medication, and lifestyle and single medication will not be sufficient. So early course of the disease, higher the weight reduction, and also a typical type 2 diabetes will be definitely able to. And beyond then, that there are other factors like how people are following with the diet, whether the weight, physical activity, and other factors, and whether the amount of the, because type 2 diabetes, what we call, we try to put a very heterogeneous group of the diabetes into same basket. It's not a simple disease. It is very, very varied disease, which we often presume a type 2 diabetes. Maybe at one end there are around, I would say, when I was studying medicine around 20 years back, 22 years back, at that time in medical college we used to see lean type 2 diabetes. Nowadays what we see, most of the type 2 diabetes are overweight and obese. So that lean to type 2 diabetes was even a type 2 diabetes, but they were lean, so they had more insulin deficiency. Now you can't expect them to go into such kind of the remission. Of course, if we talk about the overweight and obese type 2 diabetes, we will definitely expect they can go into remission, provided they are able to follow the things which we have discussed above. I hope I'm able to clarify.
Yes. Yeah. So what both Dr. Tripathi and you suggested is like 8 to 10% weight reduction is very important. Dr. Mahadev bhai, what do you think? Like, see, if 8 to 10% of weight reduction, so that comes to 8 to 10 kilogram of weight reduction. And if we really want to reduce that much, then definitely person has to reduce the calorie intake, because otherwise I don't see the person will lose weight. So how much calorie restriction do you recommend to your patient for weight reduction?
Yeah, first of all, it's probably one of the easiest question to answer, but to get the results from the patients.
Exactly.
That lose
So
weight, saying that losing weight is very simple, but it's not that simple in reality. And that to sustaining the weight loss is more important than losing the weight. Anybody would be given the complications and some scary data probably might lose the weight for some time, but to maintain that weight loss is very, very difficult. And as Dr. Mishra Sahib has already answered the questions about the percentage of weight loss. Another important thing is that we as Indians have a different markers for the obesity and overweight, right? In India, probably more than 25 BMI kg meter square is obese. And second part is we know that diabetes control is straight away related to insulin resistance, which is related to the extra fat that we accumulate in the central part. So it's not only the body mass index, but also the waist circumference, which is equally important. Any Indian with more than 90 centimeters men or more than 18 centimeters women should also be considered obese, even if their BMI is not that high. So that's another important thing we impress upon the patients about the waist circumference and reducing the central obesity, because that's straight away linked to insulin resistance. Now, practically, yeah, if you have to lose 1 kg weight, we have to have at least the deficit of 7,000 to 7,500 calories in total, which we can get it either by consuming less calories or spending more calories. And usually the best thing is to have the balance of both. So what we advise patients that at least take at least 250 to 400 calories less and at least consume 250 to 300 calories more, then only you can lose. And the target should also be achievable or modest, which is realistic. We can't tell them to reduce the weight by next month or next 2 months, but losing the weight of 1 to 1.5 kg, right, a month is achievable. And we tell the patient that that will come to around 12 to 18 kg in a year or 1.5 months, that per 1.5 years. So that is something patients can easily get convinced. So what I feel that important thing is, as I said, the central obesity we have to convince that that is very important, and losing the weight by calorie counting, and they have to be calorie conscious. Whenever they eat whatever is offered, they must know that how much they will have to work hard to digest this or not to lead that to weight gain. So that if we can make them calorie conscious, or we make them smarter enough to read the labels of the calories on every food item that they consume, probably it might go a better way, because we are all thick fat Indians. We may not be having more BMI, but we are definitely obese by these obesity standards.
yeah, that's very true, because
And another important part, probably, doctor, that now we have got medicines which can also help in the weight loss. Earlier, we had medicines in the form of GLP-1 analog agonists, which are the injectable ones, liraglutide and dulaglutide. Many of you might have heard the name, but now we have got the oral equivalent of the same group, that is semaglutide. If budget is not a constraint, then definitely it will help us in reducing the weight. If we can sustain a weight loss of 10 to 15 kg, it will definitely help. But losing a weight as low as 5% can also start many other benefits. Their blood pressure, their sleep apnea, their and NAFLD or fatty liver, their osteoarthritis, all symptoms might definitely start regressing. So it's that they have to start losing the weight and then try to achieve the ultimate goal of 10 to 15%.
Yes. Okay. So let me clear at this stage that weight reduction, if you are obese, it's very important, because 8 to 10% weight reduction, or like as Dr. Tripathi said, that if you bring your BMI less than 25, your chances of diabetes remission are pretty high or pretty good. So with that in mind, the one option is calorie restriction. The another option is intermittent fasting. It has become really very popular nowadays. And I've seen people losing 30 kg, 40 kg with intermittent fasting. So, Dr. Tripathi, what are your views about using intermittent fasting for type 2 diabetes? How safe it is and how risky it is?
Under proper medical guidance, because their doses have to be adjusted, insulin has to be adjusted. We've been actually doing it for the last 10 years. It's reasonably safe. But if one does it on oneself and the doses are not adjusted, then there can be definitely challenges that they might go through. Also, body is very intelligent in general for most of us, unless and until we damage it so much that it starts behaving badly. So when people follow a certain regime of intermittent fasting, let's say 16-8 or 2 meals, what we've usually seen is after a certain point of time, there's a plateau which comes in. And the plateau comes in because body is intelligent. It will lower the temperature a little bit to conserve the calories, because it knows I'm getting less calories. And no matter how much you exercise, that is not the major source of calorie burning. It's the resting state metabolism. It's your daily activities with your, muscle size, your basic metabolic rate is what is really burning the calories. So the moment temperature is reduced a little bit, okay, and the moment 1 or 2 months have gone, and then the festival comes and the Diwali happens and the Holi comes and the Ganesh Chaturthi will come, and India is full of festivals, and even if the person wants to control, as Dr. Desai was saying, okay, reduce 250 calories while eating, increase 250 calories of expenditure, all these calculations just go out of the window. That average 1.5 kg happening per month, it's very good linear calculation, but I find body is a very non-linear entity. Human beings are very non-linear entities. We are we're not logical creatures, we are psychological creatures. So that kind of, puts a big spanner in the whole game. So what it really works in intermittent fasting is graded. You do a certain level, let's say 2 meals you're trying, fair enough, good. You're getting a certain result. And the moment you see some plateau happening, you go for a single meal, for example. Okay, alternate day you can do single meals, or then you can do single meal every day. Then you can also do 2-day fasts, 3-day fasts. We've done 7-day fasts. We've helped people do 15, 16-day, 30-day fast also. But the point is that has to be a part of a phase. It cannot be perpetual. You have to get into muscle building after some time, because it's very easy for that weight to rebound the moment you attend a marriage or go for international travel and many distractions that we go through. So intermittent fasting is a big yes, under medical supervision, okay, graded and also adjusted considering acid reflux and headaches and many other things that kind of come up. There has to be a big ammunition of hunger suppressants and proper guidance as to what you can take during that time, and doctors, diet experts, phone call away, and then you go full on. We've got 4 lakh kgs weight loss done till now in last 10 years. So it's not that it's not possible. It's a big thing, just that it needs to be guided properly.
Okay, thank you. So that's very true that there are some issues with intermittent fasting, and reaching a plateau is probably one of the major problem with intermittent fasting. And the second problem you also highlighted, that rebound weight regain is another problem of intermittent fasting, because no one can maintain intermittent fasting for lifetime. At the most, you can keep it for 1 year, 2 years, but ultimately then once you stop, you start regaining weight. Even I have experienced that, and I am also like feel that intermittent fasting, yes, for time being it's useful, but not perceptual. What you said is very right. So now we come with that broad understanding. Now we come to a specific diet, and what we are going to do, we are going to select a topic which patient ask us or our friends ask us. So I have maintained the list of few questions which I'm going to ask you one by one, and I'm going to take each component of the meal. So let's start with the most common thing, which I'm sure most of the North Indian people and Gujarati, Maharashtrian, they are consuming is roti. And wheat is a very important component. And as I understand, 60 to 70% of the wheat is carbohydrate. So I would like to ask Professor Mishra about what are your understanding about wheat and what you suggest to your people, because you are practicing in North India, so a lot of people must be asking about roti, naan, parotha. So how do you suggest them? And one more question I would like to ask is, there is one brand of wheat which is called a kapli, which is probably from Pune side. So what is your experience? Does it really a safe wheat, or again it has to be in moderation? Yes, sir, please.
So I think this is a very important question and good question. Many times people will ask, and they will come that can we stop wheat, and stopping wheat without any rationale is going to help us in diabetes control. This is a big fancy kind of the diet, and some of the nutritionists will start telling people stop wheat, start blaming wheat. So what I say to them, first thing, that had it not been for the wheat, we would not been here, because our forefathers and our generations ate wheat, and that's what we've been surviving, because wheat was the only food available at that time. The problem is not with the wheat. The problem is how wheat is eaten. We have inculcated the American style of having the wheat, where the wheat is processed. You take out the bran, and then you put the bran on the top of that. Then the companies will sell bran at a very high cost, right? So first you make a refined flour, and on the refined flour you put the wheat. So that is one. So the processed and ultra processed food are the problem, not the whole wheat. First thing is that. Second thing is the amount of the carbohydrate being eaten in form of the wheat. It's also increasing and increasing. Exercise is decreasing. So people are doing less exercise, people are eating more food, the calorie dense food people are having, and most of the time those processed food are not simply the carbohydrate, the fat and other foodstuffs are also there in those carbohydrate based processed food. So therefore my take home message is that you can have wheat, but try to have the whole wheat food stuff, chapati, or even you can have a paratha at home with a little amount of ghee. It's not going to kill you at all. The second part is that the amount of the carbohydrate being eaten through the wheat is also should be taken into consideration, because you have a set amount of the calories for the day, which you can have together in the breakfast time, or you can spread out throughout the day, or in 2 meals, intermittent fasting, that were what we have discussed. The third part is that now finally coming about the specific, because there are fancy type of the wheat, khapali wheat, the black wheat will also be sold, and different kind of the MP wheat, and so some eastern UP wheat. So all these things, the difference is that the small difference in terms of the fiber, protein and carbohydrate into those wheat. But again, the final take home is that the amount of the wheat taken, or the amount of the food stuff taken prepared from that particular wheat, is also final important ingredient. So those things will definitely benefit, but the proportion of the benefit, particularly from that kind of the wheat, will be determined by how much you've been taking. People who have not access to those wheat stuff, do not run for finding those khapali wheat or any kind of the different. You can have your regular roti from wheat, but try to have the whole wheat roti. Don't eat the processed flour, the maida, what we commonly call is that. Go for the whole. Don't try to put a bran on the top of it. Rather than go to the chakki and get your whole wheat atta, rather than taking the maida wala atta and then putting the bran on the deck, and eat less amount, more fiber and protein. If you are not able to have the access for that kind of the costlier wheat stuff. Okay, I hope I'm clear.
Yeah, so you clarified that the wheat which we are eating should not be like the fine one with a fine flour, something like maida.
Yeah.
That should be avoided. That's one important point. Now, the second component of diet is rice. So what are your views about rice?
Of course, that becomes a very important aspect, especially when I see people who are coming from Bihar and East UP, Eastern UP. So if you do not allow them to have rice, they will feel they are restricted, and then some kind of the burden of carrying with the diabetes, right? So, and especially also people who come from the Kashmir. So rice is important aspect of them, and it doesn't mean that rice is the only factor which causes diabetes. Had it been so, so why everybody in the Bengal would be having the diabetes, or in Orissa having the diabetes? So it's not the problem with the rice. The problem is that how we eat rice, right? So and what are the other food stuff being taken together with the rice? People can have rice. So if you go into the detail, the amount of the calories in or carbohydrate in a particular amount of the wheat and rice are almost equal. The only problem is that rice, the quantification is very difficult. Roti, you can at least number 1, 2, 3. Although in India is again very standardized. A roti in UP and Bihar and roti in MP will be entirely different in the size and the thickness and how it is made. So it is always very difficult to standardize. But again, you can number it. Whereas in the rice, it is very difficult to quantify, because and people will have in plate, and then again it's very difficult to calculate. So when people are eating rice, what I tell them, a small half katori of rice is equivalent to one small chapati. And if you are allowed to have 2 chapati, you can have 1 chapati and half bowl of rice. And but in that half bowl of rice, they make it at least more than half full with the dal, more vegetable and salad, and then you can have. So people can have rice. They should not be deprived of the rice, and they should not feel deprived that they cannot have rice. Then amount should definitely be taken into consideration when you are having rice. And when you are having rice, you need to more rice, then you need to take into account that you have not taken other carbohydrate from the wheat and the in form of the chapati and other thing. So that is, people can easily enjoy having rice. What I would say.
Okay, so that's very important, that try to restrict the amount of rice which you are eating, and at the same time try to eat with dal or the salads. So that would probably reduce the
glycemic index.
Yeah, exactly. And then coming to the last, another component is millet. Because now in India, the millet has been popularized as like it's going to be a panacea for everything. So what are your views about millet? Don't worry about the government propaganda. We are discussing science.
I'm so thank you. See, millet are any food stuff which is not processed, which people are eating as a whole grain, right? Millet are small seed grasses from where we are getting those grains. So, and it's very difficult to process them. So people will take it whole. They are definitely considered to be a superfood nowadays, and many people in affluent people will try to seek for those grains. So there is no problem having the millets. The only thing is that definitely these are the rich, more fiber containing food, more protein compared to, and less of the carbohydrate, more complex carbohydrate, and give more satiety compared to when we are having the rice or the wheat based flour, and especially the refined flour. So definitely these are a good ingredient to help people in terms of the glycemic control. Glycemic load is also become less if you take into account. Satiety is better. Everything is better, and also if you take into account finally the cost, so most of the people who are able to afford it, it's good, but people who cannot afford, they can still have their regular meal. The main take home message from my side is that try not to have the processed food. Try to take into the amount consideration of the total amount of the calories you are eating, and also try to enjoy the hunger. You have to have the hunger, and don't try to time the meal. Every time you are eating and eating and eating, and you stop having desire to have food. And also, every household, there should be a weighing scale, right? For our bank account, we do have a passbook where we do check how, or digital or whatever way amount of money we are having in that. But for our body, if we are putting on weight or losing weight, most of the time, most people do put on weight. So people should have a weighing scale at home. Every month, every individual should have the weight chart and try to see if whole home is gaining weight. So there is a problem in the home. That means we are having more calorie dense food. Fridge is stuffed with the processed food articles, the juices, the drink, soft and beverages, sweets and all, and easy access to those food stuff will definitely result in weight gain. Then the smaller part definitely come out with the kapali wheat, the millets and other things. But still, you can enjoy everything and take those simple things into account. Thank you.
Okay, thank you. And what you rightly mentioned, and I'm going to ask the next question to Dr. Tripathi about the fruits. The sir mentioned about the juice. So there is a lot of confusion amongst diabetic patient about the fruit, which fruit are safe, which fruit they should have in moderation, and which fruits are no. So can you give simple guideline about the fruits?
So when the sugars are high, let's say above 7 HbA1c, 7.5 HbA1c, 8 HbA1c, it's good to be very low on fruits in general, because fruits are basically carbohydrates. If you remove water, it's going to shoot up the sugars. And amongst fruits, there are three categories of fruits: low glycemic, medium glycemic, and high glycemic fruits. Again, how many fruits you have, that will determine, and also the load of that particular fruit, whether the sugars will rise or not. So there's a lot of science behind it. But for the audience, for simplicity's sake, let's say if you take lower glycemic fruits like apple, pear, cherries are really low glycemic, berries, strawberries also, kiwi, dragon fruit, star fruit also, which is not used much, but it's a very interesting kata fruit. Then they are much safer. Okay. Then the medium glycemic fruits will start coming up in terms of, medium ripe bananas, mangoes, grapes, some degree of figs, also papaya, and they can be had when sugars are under better control. The highest glycemic fruits which we find are like very overripe bananas, suppose, if you look at them, or a shocking fruit which many people get, foxed with, or, googly dusra hai wo, out ho jata hai, wo hai watermelon. During summer season, many diabetics eat a lot of watermelon. Pani hai, it's only water. But they don't know that the glycemic index of watermelon is very high. But load is less. If you just have one piece of it, it's very satisfying, but people will have a lot of it. So watermelon is high glycemic. All the melons you need to be a little careful of. Pineapple also to a certain degree, it's medium to high. Even for that matter, jackfruit, ripe jackfruit, you have to be careful about that. And we prefer that, it's good to combine fruits with, let's say, some greens, like a smoothie in the beginning, before you start having fruits by themselves. You can have fruits at 11 o'clock, 5 o'clock as snacks, but little later when you are on the reversal path and you're doing a little better. So that's, in short, my take on fruits.
And what about the mangoes? You forgot the important.
Medium glycemic. We promote a lot of mangoes eating, but again, you should check. एक शब्द सबको दे देते हैं और वो है औकात. मतलब you keep checking औकात कितनी है. एक मैंगो खा के देखो 2 घंटे में क्या हो रहा है. Check after a couple of hours. Eat 2 mangoes, eat 3 mangoes. And once the body starts behaving better by stopping a lot of mistakes we do, and there's a reversal gear that the body is in, it is able to handle mangoes. It's not such a dangerous fruit as is popularized. Okay. In fact, I find watermelon more dangerous than mangoes.
Okay. Then coming to the vegetables. So we discussed the fruits. Now, what about vegetables? Or vegetables are safe?
Vegetables, again, the way we understand vegetables are, let's say, green leafy vegetables as one category. Then we have all the gourds and a lot of related families over there. There are cruciferous vegetables that are there. And then there are root vegetables, which grow below the ground. And green vegetables are the lightest. And if you don't cook them, if you have it again as some chutneys or smoothies, it's got a good content of chlorophyll, which is very, very useful for the body. So those are very important. Many people make a mistake. We have green leafy vegetables cooked every day, but we know once we cook it, 50% protein gets coagulated, chlorophyll completely dies, vitamins, minerals go off. So like even fenugreek for that matter, you can make amazing salad of fenugreek. It's quite tasty. So some greens, either in the form of some salads, some chutneys, some smoothies, very useful. Gourd family, bottle gourd, and all the related rich gourd and snake gourd, and all of them are again very good for the digestive system. Many of them have anti-inflammatory properties, and they are highly recommended for diabetics and otherwise also in general life, even for obese people. If you look at cruciferous vegetables, again, the cabbage and broccoli and others, they're also very useful. We find that many of them have certain properties which are anti-diabetic. Like if you look at bitter gourd in the gourd family, it's popular now. It has certain properties which are anti-diabetic. Cabbage has certain anti-diabetic properties, and we can benefit from that. Even for that matter, ivy gourd, tonli, chota sa hota hai, ittu sa. Okay, that's also very, very nice vegetable for diabetics. Besides bindi, which is okra. And then comes root vegetables. Of course, thyroid patients have to be careful of cruciferous vegetables. Root vegetables, and you'll have carrots are there, potatoes are there, sweet potatoes are there, yam are there. And they would be a little higher on the starch or carbohydrate content. So one has to be careful about them. One need not avoid them completely, but quantity restriction, especially in the beginning phase when you're reversing, like potatoes, very few pieces can be as a part of a bigger vegetable. Sweet potatoes, many people don't know, are safer than regular potatoes, regular white potatoes. So on a lot of fasting days, we promote sweet potato. A simple, grated sweet potato with a little bit of tadka, makes a little steaming, makes an amazing salad and very satisfying and gratifying thing. Yams also to be careful about. Carrots also, So you just kind of be little and have variety of them, because the color in the fruit and the vegetable comes because of the phytonutrients inside them. And every phytonutrients, and we know now more and more, the enzymes, the phytonutrients, the antioxidants is the real area in which more and more, experiments and benefits are happening. So we need to kind of make that happen.
Okay, just one question about the root variety, onions. So where does it stand? It's as bad as potato or?
Very, very good question. In fact, onion, I was reading some book, I forget the reference of that because I love reading. It is said that onion juice in a sterile condition, if taken in an injection and injected into blood, can reduce blood sugar in a dose-dependent manner. And there might not be some extensive experiments on it, but the book did mention about that. So onions, and even for the matter garlics, the sulfur-containing, vegetables that we have, they are extremely diabetes friendly and recommended, unlike the other root vegetables. So very good question. Thanks for asking that.
Okay. But just to clarify that we are not suggesting injecting onion juice to...
No. That disclaimer you given in the beginning only.
Yeah.
So just for people to remember the data. Look, sometimes what happens when you tell a story or a experiment, suddenly the importance grows. They recognize it better. That's why I have shared that. Please don't do such experiments. And medicines are medicines, vegetables are vegetables. Let's not confuse them.
Right. And then the another component is legumes. So, Mahadev bhai, what do you think and how do you recommend to your patients about legumes?
Yeah, legumes or lentils are, which is the part of the pulse family. They are very essential part, especially most of the people who are vegetarians. Because for vegetarians, the important source of proteins is either the legumes or lentils or nuts or the milk and milk products. That is the main source of proteins for us. And in that case, lentils and second part, as Dr. Mishra has rightly said, that when we combine rice or wheat with legumes, it will reduce the glycemic in load as well as the glycemic index, and it also reduces the increases the gastric emptying time, and it will also burn calories by itself. So legumes or dals are a very important part, and it is eaten with rice, and also as salads we can have it. And even some people make sweets out of it, like mung dal halwa and all. But that's not something we definitely go for the protein intake. But they are very important part, and because they have got a good source of proteins, around 12% of the 10 to 12% of the proteins, and the carbohydrates are around 25-30%. Important part is the dals do not have much of fat, so that is why the calorie consumption per gram is less than compared to the other food. And definitely it there is a problem of digestibility. Not every dal is consumed by every person is easily. Some people do get flatulence and all, so one has to make out. Especially chana dal and rajma are something that many people have a lot of problem of digestibility. The mung dal, the masoor dal, tadka, the stoor dal, they are definitely and easy to digest and very important ingredients, and should be a part of our regular meal, especially when you consume the carbohydrates in the form of rice or the wheat. And at least we should have 50 grams of dal per day consumption. That is what is recommended, and mainly because it has less fat and more proteins, and carbohydrate is around 20-25%.
Yeah. So, if we like in nutshell, there is no for legumes. All legumes are safe. Okay. Then coming to the nuts, which is another important intake for most of us because dry fruits are becoming nowadays very popular. So what is your intake about or take about this? Like how much intake is safe?
Nuts are definitely an important part of the protein as far as the vegetarians, as we said, for the lentils. The only important part is nuts are definitely having a calorie dense, very rich. So if you take 100 grams of any nut, practically it will have 500 to 600 calories, which comes to about a meal. That is what we advise. So you have to keep in mind the calorie part of it is very important. Saying that, definitely nuts are a very important source of fat. Some of the mono and polyunsaturated fatty acids, which are the essential fatty acids, which are not produced in our own body, and which is required for the integrity and for, say, our cell membranes and then many functions, the enzymes. We need essential fatty acids. So nuts are an important source of essential fatty acids for the vegetarians. Only important part is that they contain fat, that means the calories, that's, but otherwise a very good source of proteins. The protein content of nuts are more than even the pulses, and it comes to around 20%, 15 to 20% of the nuts. Interestingly, nuts are very expensive. There is one part, but the one which is easily available and which is with everyone is a peanut or a
Yes.
groundnut, which is as good. If you read the nutritive values of peanut, is almost same as cashew, but somehow people do not consume as much, and they consume more peanut in another form of oil, groundnut oil. That is not something which we need to use. But if we use just like in the quantity that we suggest for the nuts, I think it is as good as cashew nut as far as the nutritive value. In fact, the cashew has more fat and more calories than the peanut. But definitely the walnut and almond, which have got a better poly and monounsaturated fatty acids, are preferred one given choice, right? But at the same time, we have to keep in mind the calorie part, and they should be part of the total calories that is contributed by the fat. Normally, we say that at least 25 to 30% calories should come from the fat. So that has to be included when we count the calories. But otherwise, nuts are a very good source of proteins and essential fatty acids.
Yeah, so what you said is like, I just would like to put it in a different way. Like for diabetes, it's okay for to have nuts. But the problem we have to take is the other aspect, that's calories. Because calorie intake is also very important for the overall management of diabetes patient. So yes, for carbohydrate point of view, it is safe. But for calorie point of view, it's really very dense in calorie, and that may lead to problem. So I'm just
And
checking
the
the
second
time,
part,
and it's
just to make
already.
one more, yes, one more. That nuts could be one of the important source of allergies because they are proteins. We have to keep in mind whenever the patients have some symptoms of hypersensitivity, they have to recheck their diet menu and see that this could be one reason. Nuts, we see many patients with the allergies, whether it's a peanut or uh, almond or anything.
Okay, fine. So I'm just checking the time, and it's 10 o'clock, and we have not discussed all the component, but fine. We have to stick to the time. And so we end the session at this point. But I'm sure that there are many points which we need to discuss. And what I would suggest and request all of you to give new date to us, and we will have the second session on the same topic, and we will continue the discussion further. Because today we discuss only the major component, but still there are a lot of things in the diet which is remaining, which we consume day in and day out, and that also needs clarification. So once again, I thank from bottom of my heart for joining this session. And once again, I will find out the next date which is convenient to all of you, and we will have a second session on the same. So thank you once again, and have a great time ahead. Thank you.
Thank you.
It
Thank
was
you,
a
Dr.
pleasure.
Dhiren.
We
Really enjoyed
yeah.
the discussion. Really
Yes,
enjoyed.
thank you. And we also learned a lot. Thank you, sir. Thank you,
you.
Dr. Tripathi, Dr. Desai.